Good afternoon, everyone. Let's go ahead and begin our webinar. Welcome to the webinar today, facilitated by the National Alzheimer's and Dementia Resource Center, formerly the ADSSP National Resource Center, which consists of our team at RTI International. Hello, I'm Sari Schumann with the Resource Center team, and I will be moderating our webinar this afternoon. The purpose of these webinars is to provide helpful, current, and applicable information for ADSSP and ADI grant projects and others in the Aging Network. Please note the webinar today is being recorded and the PowerPoint presentation will be sent to all of you after the webinar. We will allow time for questions through the webinar's chat feature at the conclusion of the presentation. If you have a question during or after the presentation, please enter those questions into the chat feature. At this time, I'd like to turn it over to Erin Long from the Administration on Aging, Administration for Community Living to provide a brief welcome.
Hi, everyone. Thank you for joining us today on this very important webinar. We are very thankful for Dr. Samus's willingness to join us and tell us about their Mind at Home program. We would appreciate any feedback you have on this webinar. If you have any comments, please don't hesitate to contact me. My email address will be made available at the end of the webinar. Aside from that, thank you very much for your time. We look forward to a good learning opportunity. And back to you, Sari.
Thank you, Erin. Today we will hear from Dr. Quincy Samus, who will speak about person-centered care for people with dementia through the framework of the program Maximizing Independence at Home, or Mind at Home. Dr. Quincy Samus is an associate professor in the Department of Psychiatry and Behavioral Sciences at Johns Hopkins University. She's an applied gerontologist, trained in epidemiologist and health services research. Dr. Samus has served as a PI or investigator on numerous research projects focused on the quality of care and delivery of health services to older adults and families affected by dementia who live in community and residential settings. She directs the Translational Aging Services Corps, which aims to support development and evaluation of innovative, evidence-based practices that address the diverse needs of older adults with mental health conditions, their families, and caregivers. She has also worked directly with a variety of community stakeholders. The overarching goal of her work is to improve care through translation of evidence-based research. We welcome and thank Dr. Samus for her presentation today, and I will turn it over to you. Dr. Samus?
Okay, thank you so much for the introduction and for the invitation to present to your group of people. So today I am going to be talking about person-centered services for dementia, and I'm going to be using the Mind at Home program as an example of one such program. Of course, there are many, many different types of programs that are currently being tested and being used, and all, there's definitely settings, there's applications for a wide range of different types of programs for different settings. And so I'll be talking specifically about the MIND program. To address, to kind of frame this in the context of person-centered care, specifically for treating and caring for people and their families with dementia, I just wanted to highlight a couple of key principles that we used when developing the Mind at Home program in relation to person-centered care. And these really focus on the multi-dimensional nature of care needs and as kind of the holistic approach, for linking family resources, community resources, medical care, and supportive care services, as well as kind of the personalization of the care plan. We often refer to it not just person-centered care, but also family-centric care, because dementia care definitely includes an assessment and focus on the needs of the caregiver. In terms of care coordination, that is very important for kind of the continuity and transition of care, and so that also is kind of part of the construct of person-centered care services that we attempt to address, so that we see both the short and long-term needs of people as they move through the disease course. So I am going to just give you a couple of disclosures in terms of my funding support. So I've received funding recently from the NIA as well as NIMH, and then some private foundations, the Associated, the Hofberger Family Philanthropies, the Richmond Philanthropies, Centers for Medicare and Medicaid Services, as well as doing some consulting for Broadmead Retirement Community. I also wanted to read a disclaimer. The project described here is supported by this grant number from the Department of Health and Human Services, Centers for Medicare and Medicaid Services. The content of this presentation are solely the responsibility of the authors and do not necessarily represent the official views of the U.S. Department of Health and Human Services or any of its agencies. Okay, so I understand that many of you are very familiar with dementia, so I won't spend a lot of time on the background and importance, but I will note that most people with dementia, as you know, are being cared for in their own homes in the community at any given time. And they're being cared for by millions of family caregivers. This is probably an underestimate because, as we know, people don't just have one caregiver. They have a whole network of caregivers in their family and friends who are working to support them and to care for them. Dementia has been shown to be highly associated with increased risk of institutionalization, high healthcare costs, reduced quality of life, as well as a number of medical and psychiatric comorbidities and complications that come along with it. In terms of families and caregivers, they are at risk for physical, emotional, social, and financial impacts as well. So this is a very costly disease in terms of emotionally, financially, and at the societal level. The costs of care are very important for many reasons, both for families and also for society. As many of you, as all of you probably have seen the New England Journal of Medicine article that came out in 2013 by Hurd et al. Estimated that the costs of dementia were highest among any disease in the U.S. And this was very striking. They estimated $109 billion in direct costs in 2010. And in terms of total costs, it ranged from 159 to 210 billion. Family out-of-pocket costs are also enormous. Importantly, Medicaid, if you look at people who have a dementia who are similar to people who don't, beneficiaries who don't, those with the diagnosis of dementia actually are estimated to cost Medicaid about 19 times more than their counterpart, and Medicaid about 3 times as much. Just giving you a visual of the spending for dementia compared to other chronic and important diseases, you can see that heart disease and cancer both fall under the estimated cost for dementia. In terms of the proportion of people estimated to have dementia in the United States in 2014, you can see that about 75 to 85, you have about 11% of a non-Hispanic white population compared to African American and Hispanic populations that are significantly estimated to have dementia at a significantly higher prevalence rate. In the 85 and older group, you can see that there are very striking and important and concerning prevalence rates for dementia, particularly among those who are non-white. And this definitely speaks to our diversification of our population, our need to really develop and test and implement approaches that are culturally relevant and sensitive. This problem is obviously not just the problem faced by Americans. It is estimated that in 2010 there were approximately a little over 35 million people worldwide who had dementia. And the number of living cases doubles every 20 years, it's estimated. So by 2050, this may mean 115 million people with dementia worldwide. As you can see from this graph, the growth really is most striking in the low and middle income countries, which means that the approaches that we're testing and developing in the U.S., we really need to keep an eye on the affordability and also potential for applications in other countries that could benefit from this. So I mentioned on the first slide our approach to person-centered care, and of course there's many different conceptualizations and definitions of person-centered care, but we really, in terms of the practical or the dementia care approach that's been really developed at Hopkins over the last several decades, primarily by persons like Peter Rabins and Kostas Lyketsos. We believe that even though there is not a cure or treatments that directly impact the disease currently, there are effective methods of treating the symptoms that can very importantly impact outcomes that are important to families and to people who are suffering from dementia, and important to their quality of life. And this approach really is a kind of a process approach that essentially is a multidimensional assessment to assess needs in many different areas. Medical, of course, is important. However, probably more important are things like supportive care, emotional support to caregivers, supportive services in the community, and preventive care. And so, so identifying these needs, treating the symptoms based on the needs that are identified, and then providing the appropriate support either through family resources, community resources, healthcare resources. This is the approach that we believe can be used to help people currently who are suffering as we wait for curative treatments to funnel down the pipeline. So what do we know about care coordination models for dementia right now? Care coordination is not it's not a new process. It's something that's been around, time tested and true for many years and used in many other chronic conditions. We have believe that this is a great vehicle for delivering care and coordinating care among different providers, particularly for dementia, for many reasons, including the fact that, as we mentioned, dementia care encompasses not just medical care, but also social and emotional care as well. And in terms of looking at the evidence base thus far, this review was actually done probably in 2013. And at that time, there were about 5 systematic reviews that had looked at care coordination specifically for dementia, as well as 2 meta-analyses. And together, these reviews and meta-analyses captured about 23 individual unique trials from 9 different countries. Now, looking at each of these trials, about 70% of these trials were rated in the reviews using their criteria as either poor to fair quality. And importantly, many of these care coordination models varied in content, and that's very important because in care coordination, your processes and your interventions are directly linked to the content, for example, of your needs assessment. So if you're not measuring dimensions of care needs that are very important for your goals, then you will not likely impact those. The care coordination models also varied in duration. So for example, many care coordination models were tested at a 12-month duration. Some were tested in an 18-month duration, and some were quite several years. The setting also differed. Some of these programs were delivered in primary care settings. Some were delivered in home settings, some over the phone with family caregivers, mostly by phone. And of course, the team composition and integration with the health systems varied, sometimes as a function of what setting they were working in. Care coordination models typically have been tested using nurses or social workers or other clinical staff as the frontline care coordinators, and the intensity of contact varied dramatically, as well as whether or not the care coordinators were focusing on directly on, with the person with dementia's needs, or with the caregiver's needs, or with both needs together. In terms of kind of looking at overall what these findings suggested, there were low to moderate effect sizes on whether or not they actually improved care quality. And so that could be measured by guideline adherence, or reductions in neuropsychiatric behaviors, or reductions in quality of life. The biggest effect size that collectively dementia care coordination models have shown is on caregiver burden and strain and depression. So those types of outcomes, it seems, are the most readily affected by these dementia care coordination models. Overall, there was really, at that time, no effects on mortality or healthcare use or costs at 1 year. However, many of these studies didn't look at these outcomes specifically, and there were only a few studies that showed a reduction in odds of nursing home placement or delay in time to leaving the home. Again, that wasn't an outcome that was a primary objective in many of these. I would say that one of the major problems in terms of some of these earlier studies that have looked at care coordination and dementia has been the kind of black box syndrome, I guess. The criticism is that everyone says they're doing care coordination, but what does that really mean? So we're not measuring, we haven't done a great job of measuring the processes for what we're doing as we are delivering care. And so, moving forward, better measures and taking more time to measure the processes of care, I think is really going to be critical in both estimating costs for how much this actually costs to deliver, in terms of risk adjusting that cost, because there's some folks that are going to be very low intensity people in terms of the contacts they need because of their individual needs, and then there will be others that will be very high. Another area that I think collectively we all need to be thinking about is also being able to, for these evidence-based models, reporting on fidelity and measuring fidelity, and making sure that the things that we think we're doing, we're actually doing, and that the model is being delivered as intended. And so that kind of goes along with measuring process and reporting on process in our scientific publications. So all of that said, overall, though there have been these 23 trials, there is the lack of high quality, blinded, randomized control, larger sample studies have been few. And so at this point, it's still difficult to make conclusions. And, and this is really, I think, evidenced by the fact that, there's not yet widespread reimbursable models for dementia care coordination through insurers such as Medicare and Medicaid. There's definitely waiver programs that may have individual care coordination and dementia-focused programs, but it's not something yet that has been widely adopted. And so I think that making a financial case is one avenue for being able to, as well as the evidence base, of course, one avenue for being able to more widely disseminate these types of programs. So bringing us to the Mind at Home program. And again, I just want to emphasize that this is one example of a program. There are many other wonderful programs that are care coordination, dementia focused, that are, have been created for home settings as well as primary care settings. And I think that, because the population and places that people receive care are so different, as well as the communities and the resources within them, I think that all of these programs have a place for use and for being successful. So this particular program was conceived by Mr. Roy Hoffberger, who is a local Baltimore philanthropist, and he has been the community champion for this project from the inception back in 2005, I believe. He, as well as Kostas Lyketsos, who is the chairman of psychiatry at Bayview, got together and they said, hey, we believe there's a significant need in the community for this type of service and for care. We think that people who, we worry about people getting socially isolated and the stigma, and there's so many families who are really struggling with not knowing what the future holds and with making decisions. And, this would be a great project if we could get it started. And so what Mr. Hoffberger did was he raised $2.25 million from a range of private donors and foundations, as well as some state money, to basically put together a program that would follow the principles of dementia care, and also with some pieces that were innovative and affordable. And so the vision was really to, come up with a collaborative community, cross-cutting, silo-breaking model that would link social service resources, medical resources, family resources in an affordable way, to really address the key goals that we believe patients and families have, which is the primary objective is to stay at home as long as they can. And so that was the primary goal for what we hope to impact, as well as these other outcomes that we've mentioned already, such as reducing caregiver burden and strain, improving care, improving patient quality of life. So in 2007, we launched a pilot randomized control trial, which was kind of the maiden voyage of the Mind at Home program. And we enrolled 303 people with cognitive disorders. Most of them had dementia, who were living in their homes in the community of in 28 zip codes of Baltimore. And it was an 18-month randomized control trial where everyone who was in the care coordination group received 18 months of care coordination services, and I'll talk about those in depth in a minute. And whereas the other group of the comparison group, which we called augmented usual care, received a multidimensional intensive needs assessment in their home at the beginning, and then their families and their physicians received a letter that basically outlined any identified needs that we found, as well as potential interventions that could be used to address those needs. The sample itself was, the average age, I believe, was about 84 years old. The 70% of them were living in the home with a caregiver, and 30% were living alone. The average mini-mental was about 19. Roughly half of them would have fit into what you would call the mild dementia. group, but we did have a significant portion of people who were both moderate and also severe dementia. So we had some people who were actually bedbound participate in the study. We also had about 29% were not white, and this reflected pretty much the census demographic breakdown for racial diversity in those areas. So we think it was at least somewhat reflective, maybe, of the community that we were in. And so to kind of give a little bit more about the care coordination intervention itself, so, so this is a chart that kind of shows the core components, and, the theories that it's all based on are patient and, I should say person and family-centered care, as well as the Wagner's chronic care model. The team was composed of coordinators, and so these were actually non-clinical community workers who received an intensive training for the Mind at Home program at the beginning when they were hired by a geriatric psychiatrist and a geriatric mental health nurse. And over time, they had continued support from the clinical team members, but they were actually doing the lion's share of the work with the families and the persons with dementia or cognitive disorders, which is kind of one departure from a typical care coordination model where you have a clinical staff team member doing much of the direct contacting. As I mentioned, they received an initial training. This included classroom instruction, observational learning, modeling, guided practicing of techniques, and then ongoing and frequent mentoring and direct support. So there were weekly 2-hour case meetings as well as individual meetings, staffing and services, and then direct access to clinicians at all times. If questions arose, as well as the clinicians were able to go out into the field and go into homes as well if there was a situation that warranted that. In terms of the tools, this is another important part of developing care, or any programs really, is the manualization and standardization of the curriculum and training manual. And so we have a written manual, as well as we developed a specific dementia needs assessment tool that drives all of the interventions that we use. It's evidence-based and also clinically relevant. And we also developed which I think is absolutely crucial to this kind of thing because you have so many moving parts, essentially an electronic medical record for the care team to use when tracking their progress with their clients or participants. And we called that the Dementia Care Management System. So what were the techniques that we used? So much like other care coordination models, we did this needs assessment. We did a tailored, individualized care plan that took into account the patient, the family, and in terms of their preferences and priorities for what to work on first. We provided appropriate referrals to community resources, provided education and training and kind of empowerment to the family caregivers, as well as skills, problem-solving help, and teaching problem-solving techniques. And then we monitored and reassessed how their care plan and the implementation of these strategies were going over time. Dementia is, as you know, dementia, there's no single silver bullet for any given problem. And so it really encompasses a lot of trial and errors. And so for any given need that that we assess, there might have, that there's a range of tools in the toolbox that we, had put together as available, based on the literature and evidence-supported um, care management approaches. And we would try things, and many times the first things that we tried, of course, wouldn't work, and the second things we tried wouldn't work, and so on. But the important thing is that regardless of how bad the situation is, there's always something, however minor, that can be done to improve the quality of life. And, just to give an example, we might have gone to homes and identified 15, 20 different unmet needs related to their physical environment, clutter, hoarding, um, not having legal documents in place, advanced directives or behaviors. But, the caregiver and family, their main priority was to get the air conditioner fixed, or to, so it's meeting them where they are, building trust, and then moving on, and then negotiating and moving on from there. And that's something that we're still learning how to do. Okay, and so then also community resources. So, so this is not just a medical condition that we're treating, and so it, of course, necessarily needs links to allied health providers, physicians, of course, clinicians, but also allied health providers, social services, um, local and state area agencies, home care services, adult. The list goes on and on about all the different service providers that are important. All right, so what do we feel are the key ingredients for this particular model? Well, the tools that we developed in the manual and the interventions that we linked to each of the unmet needs were all strategically based on best practices for dementia care, both from trial research, from epidemiological research, from interventional research, as well as clinical dementia care experience of the investigators here at Hopkins and elsewhere. It really is meant to be best practices in every sense of the word, and definitely evidence-based, evidence-supported activities. As we mentioned, attention to all aspects of care, because medical care is certainly important, but social supportive care are sometimes even more important depending on the individual. In terms of the family-centeredness of dementia care, so as I mentioned, we focus both on the patient and the caregiver, and we really, focused on empowerment of the families by providing education, skills training, self-management, approaches and emotional support. And so, knowing that the intervention was only going to be delivered for 18 months, we really wanted to leave them with the kinds of skills and knowledge that would help them identify when something is a problem, and to know the appropriate ways to either problem solve themselves, or to go and ask for help either from their primary care provider or from others that are relevant. The team composition and delivery model. So we really wanted this to be breaking down silos and really linking kind of the medical and community-based care services, as well as opening up the possibility that a future workforce, so the people who were care coordinators who could potentially do this later, would be as broad as possible. And so by having non-clinical staff supported by practitioners, provide the intervention and do much of the legwork and much of the interactions with the families and the persons with dementia, we really felt that this was, a model that would be more inclusive for potentially people who could carry this out. The IT system, of course, was key to delivery, so being able to effectively and efficiently track track care that was being provided in progress. That was very important. And, you know, I could talk about it now, but some of the two studies that we have going on currently that I'll talk about, their major goals are to really estimate both societal cost impacts or effects of the model, as well as healthcare impacts. Based on 2009 estimates from what we had during the pilot study, we really think that this kind of system for an average client could be delivered for around 2,000 to 2,500 per patient per year, depending on what components are in the model or in the program that you're talking about. So I'll talk about that in a minute. We have what we call the Mind Streamlined model right now, and another iteration that is called the Mind Plus model, which is a more intensive model. But you know, this is really not, not a lot. And so we're hoping that this actually is, close to what it actually costs, and we're going to find the answer to that, hopefully in these two trials that we're doing. The final key ingredient is that the model is really meant to be appropriate for all persons with dementia, regardless of the stage of illness, their socioeconomic background, or circumstances, or their racial background. For example, the needs assessment is so broad and captures so many different dimensions that some people with milder dementia may have more common needs in various domains versus someone with severe dementia. And so having, your assessment tool cover that range was important for us. In terms of unmet needs, so what did we find from the pilot study? So we found that, no surprise, safety and personal and home needs, like these included things like structural issues, exit control issues for wandering, fall risk issues, just comfort issues, heating and cooling, fire hazards, smoke detectors not working, etc. Those were found at least one unmet need in that category in about 90% of the homes that we went into, of the 300 persons with memory disorders that we saw at baseline. Other prevalent needs were for general health and medical care, for meaningful activities. Many of them may have didn't have a daily routine, or they sat in front of the television for the majority of the day. Legal issues and advanced care planning are another important need that we found. And, if I remind you about the breakdown of about 50% of these folks were in the mild stage of dementia, just based on a mini mental cutoff score. And that is likely the time that, they are still able to make their wishes known in terms of what kind of care that they would like for end-of-life care, and so that's an important need to address at a critical time, such as in the milder stages. In terms of evaluation for dementia itself, a little over 30% of these folks had not yet been diagnosed by a healthcare provider as having dementia. However, at the clinical assessment that we did in the home, they did meet criteria for dementia, DSM criteria for dementia. And then an assorted range of other, issues that were prevalent, assistance, with bathing and IADLs, medication administration and management issues, and that's a huge one. Treatment of neuropsychiatric symptoms, behavior management, and the list goes on. In terms of caregivers, we found that many of them could have benefited from a better knowledge of the resources that were available to them in the community and how to access those, as well as education about the disease itself. Many caregivers I heard complain that the doctor did give them a diagnosis of dementia, but they didn't tell them what to expect and what this was going to mean in the future and the overall course, which is very hard sometimes depending on the type of dementia. But that education about what's typical, what's not typical, changes in status, like, when to call the doctor, if you suspect delirium or a UTI. Those are things that can be taught and can help caregivers feel more in control of the situation. Um, and also caregiver mental health. That was a big one. So many of them, about I think a quarter of them, using a depression clinical cutoff score, did have clinically significant symptoms of depression. But many of them had, kind of non-clinical, but still significant feelings of being overwhelmed and mildly depressed, and these are all things that can be addressed through care coordination models and linking them to either if it's a pastoral care or if it's a psychologist, depending on what they need. All right, and so in terms of what we found for the outcomes, for people who receive the Mind at Home program for 18 months or up to 18 months, compared to folks who were in the augmented usual care, they were less likely to leave the home or die over the observation period. So 31% versus 46% had that kind of event at 18 months. And these are what we call survival curves. And so the black line is the Mind at Home group, and the gray line is the usual care group, and time is on the x-axis. And what we call survival, or risk of having an event, is on the y-axis. And so going down is bad. And so as you can see, they kind of hang around together for the first about 200 and some days. And then they start to separate in graph A. And then graph B is over an extended time period where we didn't provide any more services, but we just kept tracking if people were still in their homes or not. And at a median of about 2 years, what we found is that the people who had received Mind at Home, on average, had a delay in transition or death of about 288 days. And so that's what made everyone so excited about this program, was that there was not only a 51-day initial average delay at 18 months, but the delay actually appears to last. And so we're doing a follow-up larger trial right now to find out more about that durability of impact. Uh, so let's see. I'll also point out the fact that we didn't see these changes right away. And that really speaks to the time that it takes to get care coordination up and running, so to speak. It takes time to build rapport, to gain trust. It takes time to, meet their needs, whatever they are. If it's something where they have to fill out a waiver application, and then they have to wait several months for a decision to be made, and then they have to, many of the interventions that are used in care coordination are not just something simply that's like a silver bullet where you take care of that, you wash your hands of it, and you move on to the next thing. Again, it's the trial and error. It's, it's really about connecting with the family, meeting them where they are, and then working with them over time. And so this kind of shows that it's not an immediate thing. And so that's why we were very happy that we did design this so we had an 18-month period where we were able to provide the intervention. Because if we had been, given this potentially 12 months, we may not have seen the same type of impact. In terms of looking at unmet needs, so total percent of unmet needs over time, this is just a simple graph looking at baseline and at 18 months for the two groups. And I'm running a little bit, okay, I'm running a little bit too long. So essentially there was an effect, although not nearly statistically significant on that. We improved quality of life and in the care coordination group, while the control group actually had a lower score at the end. And then in terms of caregiver benefits, the ZERT burden measures subjective caregiver burden. We were able to nearly have a significant effect in terms of lowering that, 0.06. In terms of the hours per week spent with, for the mind group it went down, and for the control group it went up. And so if you look at the difference of slopes between the two, there's actually about a 16-hour difference from baseline to 18 months between the mind and control group. And so that is significant in terms of time savings potentially for caregivers. So this is the developmental path of the Mind at Home program so far, and where we are now. So we've done a few things since the pilot trial to enhance the health record that we're using, the health system. So now we have a round 2 CMS Innovation Award that we're looking at to really estimate the effects on Medicare and Medicaid. And primarily we're thinking that it's going to be a Medicaid savings due to reductions in nursing home placements. This is a demonstration project where it focuses strictly on dually eligible persons with dementia. And again, we're looking at really delaying or reducing nursing home admissions for that population. In addition, it's going to help with dissemination. So part of the aim of that project is to develop a certification program that's web-based, that it would be an online platform for staff and study team members, or not study team members, care team members to participate in, so that they would be certified to carry out this program in their own locale. Simultaneously, we have the CMS award is also testing a more intensive and augmented iteration of the MIND program, what we call Mind at Home Plus. And what we've done is taken a streamlined version of the MIND program, and we've beefed it up by adding an occupational therapy tailored activities program component for people who have behavior problems, that has been used successfully by Laura Gitlin and colleagues to reduce caregiver burden and neuropsychiatric symptoms. So we really think that that's going to be a good augmentation to the project. Simultaneously, we have a randomized controlled trial that's being tested on to give us some very scientifically rigorous single-blinded trial looking at a kind of leaner, streamlined version of the program, and to get a better understanding of how that delays time to long-term care, as well as durability. Also looking at cost savings from a larger societal level versus just within Medicare and Medicaid, and also the moderators and mediators. Okay. I'm sorry that I ran over. I don't know what's happening now. I guess I went too fast. So I'm gonna stop there to allow time for questions, I think. I'm sorry I didn't get through the whole thing.
Oh, that's okay. We have a few questions in the queue, and thank you for your presentation. We also will be sending out the slides, so folks will be able to see the rest of the presentation when we send those out at the conclusion of the webinar. So we have a few questions here. The first question that came in was, what would account for the higher proportion of Hispanics and African Americans who have dementia? Do you have any theories? So it's not directly related to your presentation, but more to dementia overall.
Sure. Well, so there's a lot of debate about that. And so one, I guess a couple of factors that are most highly regarded as functions of that are differences in genetics, cardiovascular risk factors in diseases, as well as disparities in healthcare access throughout the lifespan.
Great, thank you. The next question was about the Mind at Home manual. Is it available? And then is the electronic record keeping tool available for viewing?
So right now, those two things are not available, but that is one of the main purposes for the objective of the CMS Healthcare Innovation Award is to have those tools refined and finalized so that they would be available. So they're not available right now.
And when they are available, will that be posted on your project's website?
Yes. So I'm sure. Yes,
so that's
absolutely.
something folks can keep up on and check out the website.
I will warn that we're coming to the end of our first year of the CMS, so it'll probably be about 2 years, to be completely honest.
Okay. And the next question, can you talk a little bit more about what the average amount of contacts the care coordinator had with participants? So about how often were they meeting or calling the participants over the course of the 18 months?
Sure. So on average, we saw people a total of, let's see. So it was about 2 contacts per month for 18 months on average. And the majority of these contacts were by phone. About 70% of these contacts were by phone. And the average in-person, in-home visits over the 18 months period was about 5.
Okay, great. Let's see. One person was wondering a little bit more about the certification program. If there's information you have about that you can forward to me, I can send it on. Do you have any comments about certification?
Yeah, so we are actually right now, again, that's kind of part of developing this care program package that would be, available for dissemination. Which would include, we kind of see this program as having a package that includes the care needs assessment, the manual for the protocol manual, as well as the software system, all integrated within a certification program that's web-based. And so all of those things are things that we are actively working with, like folks at instructional design, for example, to develop like the interactive certification program. So, I could give you kind of the major categories of content at this time, because we do have that. But I wouldn't be able to show, we don't have any screenshots or anything like that to show.
Okay, yeah, if you would like to send those categories to me, I can get them to the person who asked the question.
Sure.
And then another person asked about how effective you think the model might be in a rural area.
Well, that is a great question, and that's one that we're wondering ourselves. So, a lot of it has to do with referrals to community resources, and so obviously there's going to be stark differences between a metropolitan area in terms of the resources at the community level that are available versus a rural population. But the model still does incorporate, it really does incorporate a lot of education for the caregiver, emotional support, and skills training. And so it would be interesting, so those things would work regardless of, external community resources. So it's a good question. I think it's something that we don't know.
So remains to be seen.
Yes.
More work in the area will help you figure that out, hopefully.
Right.
Someone is here from Australia. That's very exciting. She says she's a consultant in aging at home in Australia. Is there a way to access the program? Do you have the website offhand, and I can type it into our closing notes so everyone can see it?
For just general information about the program?
Yeah, and then maybe if you have more specific information for the person who asked, I can
Sure.
We can contact you directly.
Yeah, could they contact me directly? And we have a website that literally is just being worked on right now, and so it's supposed to be back up like in the next week or so. So if I can make that, I can send that as soon as it's ready. It's mindathome.org. That's the website.
All one word.
Yeah, so it's mind, all letters, mind at home, and then .org.
Okay, it's in the closing notes, everyone. So you can see it down here on the first line. And like Dr. Samus just said, it's not available right now, so you'll need to check it in a few weeks. Let's see. Is there a way that psychologists could be involved in the program, or why they might not be included at this point?
There's no reason why they're not. We welcome, I think that's one of the rich features of kind of what it's kind of evolving into. We would, I think, be very happy to include psychologists. So, if that person has specific ideas, I'd be happy to talk.
Great, thank you. Let's just do, sorry, something happened with my connectivity, but one of the last question that was there that I think we'll be able to get to was what kind of meaningful activities were provided?
Yeah, so this is the exciting part. So, in the first pilot study, we had a less refined idea. We used activities, for example, that were that had been used, that are posted, publicly by the Alzheimer Association. We tried to match based on what the person's lifestyle, and preferences and their past occupation, all that in the pilot study. However, the exciting part of what we're doing now in the CMS demonstration project is that we are linking meaningful activities